Okay, in the interest of time, we are at 2 after, so I'll go ahead and get started. And just want to issue a very warm welcome to our members who are joining us today. This is an ISBNPA webinar for the Cancer Prevention and Management Special Interest Group. In general, I will give a very brief introduction. My name is Emily. I am one of the executive committee members for the CPM Special Interest Group, and I'll be moderating today's webinar. And so I just have a couple of introductory slides here and some housekeeping notes in order to make sure that we run the webinar as efficiently as possible. And so, as I mentioned, this is put on by the Cancer Prevention and Management Special Interest Group, or SIG, and we are one of many SIGs as part of ISBNPA. And the primary purpose here is to help to provide forums and to connect ISBNPA members around special interests. And one of the benefits to SIG members is that we, organize these different webinars. And so there are other webinars put out by other SIGs that are available to view and to participate in as well. And so we're just really delighted to be able to organize these webinars as an extra service for our members. The mission of the Cancer Prevention and Management Special Interest Group is primarily to promote lifestyle interventions and behavior change across the whole cancer prevention and control continuum, thinking all the way from primary prevention through screening, detection, and interventions for both patients and survivors, as well as to really think about how we can develop multidisciplinary international collections of researchers here, combining research expertise throughout the behavioral enterprise, as well as physical activity and nutrition disciplines. And so really trying to bring all of these different areas together to promote cancer prevention and management research. Our current executive team is comprised of quite a few individuals from across the globe. Cindy Forbes is our current chair, and Dr. Rebecca Beacon is our immediate past chair. Dr. Jordan Curry is the incoming or deputy chair. Leanne Shearsmith is our treasurer, has been the secretary for some time as well. Sarah O'Rourke is our leads communications officer. Eliana Karaka is another one of our communications team members alongside Dr. Laura Keever, and I am the current webinar officer. We are also looking for additional individuals to join the SIG, so if anyone is interested, please do feel free to either contact the ISBNPA general email or someone on our team directly, and we would be happy to tell you a little bit more about what might be available. I'll also note that webinar recordings are available on the general ISBNPA website after each webinar is complete, and so ours should be up likely by tomorrow, if not the following day. So these can always be watched after the live session has ended. In terms of logistics for today, all participants or attendees are muted by default, and so we will use the Q&A feature here in the Zoom meeting to be able to get all of the questions answered. And so this helps to, prevent noise, keep us concentrated on the actual talk. However, you are able to interact with us outside of the Q&A box. If you do raise your hand and you do want to be able to ask questions, you'll be able to come off mute in order to do so. Otherwise, I will plan to moderate, so you can throw questions into the Q&A feature whenever you have them, and I will wait to get them answered at the end of our presenters' presentations. And so with that, I would like to get ready to turn it over to our two amazing speakers today. Our webinar is about rethinking malnutrition in oncology, considerations for patients living with overweight or obesity. Our first speaker is Dr. Shelly Coe. She's an associate professor of nutrition science and the chair for Healthy Aging and Care, the Healthy Aging and Care Network. She's also the theme lead for the Healthy Living Research Center at the Oxford Institute of Applied Health Research at Oxford Brookes University. And her research focuses primarily on diet quality and associations with metabolic parameters in vulnerable groups. She'll be presenting today on screening for malnutrition in people living with cancer and overweight or obesity. Our second speaker is Dr. Tracy Crane. She's the Burke Endowed Professor in Women's Cancer Research and an Associate Professor of Medical Oncology and Public Health, co-leader of the Cancer Control Research Program and director of the Digital Health and Lifestyle Medicine for Cancer Survivorship program at University of Miami and the Sylvester Comprehensive Cancer Center. Her research focuses on improving adherence to healthy lifestyle behaviors among cancer survivors and their caregivers. And she'll be presenting today on treatment and research of malnutrition in oncology care. And so with that, I will turn it over to our first speaker, Dr. Shelly Coe.
Great, thank you, Emily. Let me just share my screen before I go any further, make sure it's all working. There we go. Is that visible to everybody?
I can see it, yes.
Yes, brilliant, great. All right. Well, thank you very much, Emily, for that nice introduction, and well done for remembering all of our backgrounds and our titles. That's quite impressive. And it's great to be here today. And let me just move this so I can see you more. There we go. So yeah, thanks for having me. And just to say that I am actually quite new to the cancer research field, I suppose, compared to Tracy and maybe some other speakers. But it's been such an interesting sort of journey coming into this research field. And so today what I'm going to do is present to you one of our review papers that we've recently had published, which has been fantastic. And it's going to be on screening for malnutrition in people living with cancer and overweight or obesity. So maybe sort of an emerging field of research. Now, the reason, obviously, I want to give thanks to my team. So I've included all of the authors here for this review, but not just to say thanks to them all and acknowledge them, but also to show sort of how interdisciplinary this topic is. So to actually get this review done and published, it really took, you know, a diverse team. So I come on to a slide in a minute talking about my background, but I kind of wanted to just mention, you know, how important that is. And we're also part of the NIHR Living With and Beyond Cancer group collaboration, and that's sort of how we sort of got together to do this review. And let me just go. Yeah, so about me. So thank you again, Emily, for the nice introduction. So I'm Dr. Shelly Coe. So I'm from Oxford Brookes University. Please feel free to email me or find me on LinkedIn after this. And so I do focus on sort of long-term conditions more generally, and have come into cancer more recently. So when it comes to cancer, I look at nutrition and lifestyle during a cancer diagnosis, so sort of after the diagnosis, but more specifically, maybe recently, malnutrition risk and missed referrals in people with cancer who are also overweight. So I'm definitely not going to have time to say thank you to everybody that's sort of involved in all the research I do in this area, but I've got some slides at the end with my collaborators on. So I'll jump straight into it then, because I only have about 20 minutes. So what is the background, I suppose, and why did we decide to do this review, or why is this area important? So malnutrition in cancer is linked to many sort of adverse outcomes: increased chemotherapy toxicity, treatment delays, reduced quality of life, longer hospital stays, higher costs, and greater mortality. So probably, you know, very widely known that this is the case. And current clinical guidelines do suggest screening all cancer patients using validated screening tools when it comes to malnutrition risk screening. So many tools exist, and again, because I'm not a clinician by background or a dietitian, you know, it was great to kind of work with the dietitians and clinicians to learn about, you know, the day-to-day in practice, sort of what tools are used in different hospital settings. And so there are multiple tools that exist, but what is really unclear still is how well they identify risk in those who are overweight or obese, because generally they are made for the kind of normal or lower weight, typical or lower weight patients. So malnutrition screening tools are designed to be quick and simple to use. Nobody has time, you know, time is of essence, and everybody is very, very busy. So something that is quick and easy to kind of screen risk is and feasible is what is needed. And previous reviews have evaluated tools in oncology, but none have specifically looked at patients in this population. So what we decided to do was do a scoping review, and to scope the literature more broadly to kind of really understand what the literature shows, what the research shows in the overweight and obese population group when it comes to malnutrition screening risk. So we kept our sort of criteria more broad than say a systematic review. So just a recap of what is malnutrition in those who are overweight specifically. So it can be referred to as sarcopenic obesity, and in very, very brief terms, this is a very summary of the kind of wider malnutrition definition. But high fat mass, low fat free mass or loss of muscle mass, and possible functional impairment or metabolic complications. So the kind of key thing to highlight in those who are overweight or with extra weight is BMI alone might not identify malnutrition risk. So that's why some of the tools that I'm going to discuss in a minute might not be as appropriate for this particular group. So what were the aims of our review? So the aims were to identify and evaluate published evidence. So we only focused on published evidence to inform improvements in malnutrition malnutrition screening for people with cancer living with overweight or obesity. So the idea was to look at what there is out there, in this particular group, with the aim to kind of improve research going forward or inform research going forward. So determine which malnutrition tools, or clinical measures, alone or in combination, may be effective in identifying malnutrition risk in people living with cancer who are also overweight or with obesity, and to consider the reported strengths and limitations of the screening tools and measures identified. So if I'm honest, we didn't go into this review thinking that we would find a tool that was going to, really, really accurately identify malnutrition in this group. But what we wanted to do was sort of identify tools that might not be as appropriate and ones that might be more appropriate, but also look at the components of different tools and other sort of physical measures or functional measures that could go in combination with screening tools where feasible in terms of time, to help to identify risk in this particular group. So we sort of went in with not too overly optimistic that we were going to kind of find the perfect tool for this group. And so the next few slides, I'm going to go through the individual tools that we found, and some of the kind of key takeaways from each of these tools and the papers that looked at these tools. So we included studies in our review that looked at overweight, obese participants with cancer, but if the papers also included sort of people who were overweight or with obesity within a kind of the overall population, so also included those of sort of typical or lower weight, we also included them. So they had to include people who were overweight or obese, even if that meant they were kind of part of the population pool, if that made sense. So it wasn't just specifically for studies that only looked at those with overweight or with obesity. And so what we found from the studies that were included in this review, and again, I know I only sort of have 20 minutes or so to talk through this, so I'm very happy at the end to answer, questions if I haven't been clear on anything or if sort of went through anything too quickly or missed something out. But the papers that we found were classified into three sort of distinct categories. So we found research papers that we classified as these diagnostic accuracy studies. So these studies examined how accurately a malnutrition screening tool identified malnutrition risk in the overweight obese population by conducting a concurrent validity analysis against a standard reference. So these were sort of more of the kind of gold standard papers that we included. We also included comparative studies. So these were similar to the diagnostic accuracy studies, but the difference was they didn't conduct a validity analysis. So they compared without doing that sort of validity analysis component. And then there were some studies that were monomethod studies, so use of a single malnutrition screening method without comparing. So obviously the quality of these were lesser in terms of no comparison. But again, because we were kind of scoping, what is out there, we wanted to kind of include the different levels of studies. So in our final review, and again, I'm going to go through what we found in a moment, but we had 7 cross-sectional, 8 prospective cohort studies and 1 retrospective cohort study, and we found 11 different screening tools and their subforms and measures. So we did include some tools that could be considered as assessment tools rather than screening, but we included tools that fell into that category if they had a screening component to them. So again, just to kind of keep this as wide as possible so we could understand the literature, we did keep in assessment tools that had a screening component to them. Okay, so the next few slides are a little bit wordy. The font, the text, sorry, in italics is kind of the results from the papers we found, but the text in bold is what I want to kind of draw your attention to the most, as this is the kind of summary that we got from each of the malnutrition screening tools that we looked at. So the Malnutrition Universal Screening Tool, or the MUST. So just a quick summary of the studies that we found. Malnutrition in these studies using the MUST in this particular population ranged anywhere from 34 to 70%. Compared to the PGSGA in two studies, MUST underestimated malnutrition risk, and one study showed similar prevalence between MUST and PGSGA SF. So what does this mean? So what we kind of concluded from the studies using MUST is that MUST performed poorly identifying malnutrition in people with cancer who were also overweight or with obesity, although it tends to obviously perform well in sort of normal or underweight cancer populations. One of the limitations is the BMI of greater than 20 kilograms scores lower using the MUST, so therefore reduces that likelihood of people with higher BMIs as being flagged as at risk. We also found studies using the malnutrition screening tool in this population. So in one study where 57% of the population fell into this overweight obese category, the MST was validated against CT. With results presented there, and the second reported the MST but didn't give any results. So our kind of summary again from the studies including this tool in the review is that MST does use recent weight loss and reduced appetite to screen risk. Overall performance was low. Reliance on appetite may increase specificity, but low sensitivity does limit the clinical usefulness when we consider the overweight obese population. And the next screening tool that was included in the review was the Nutrition Risk Screening 2002. So the studies here so two comparative studies reported 23.5 and 46.7% of participants at risk of malnutrition. Two monomethod studies, so where there was no comparison, found different percentages, of people who were overweight and obese, and also different risks of malnutrition as presented there. Malnutrition incident was generally reported for the whole population and not by BMI category, so sort of considered the whole BMI population. Again, this is something we found in many of our studies, that the kind of overweight obese population was sort of clumped in with sort of all BMI categories. And then the NRS 2002 was also compared against GLIM criteria with the outcome reported there. So the summary of these studies using the NRS 2002 was that it assesses weight loss, food intake, and clinical condition, and it doesn't just use sort of BMI alone as a measure of malnutrition. So I am going to sort of summarize all of these studies together at the end, but I also wanted to just go through them in a little bit of detail each. So then we also have the SNAC, the Short Nutritional Assessment Questionnaire. And so one study looked at 48% of people living with overweight obesity, and actually the subform SNAC 65 plus had a high diagnostic accuracy in the whole sample, so not just those living with overweight or obesity, compared to measures of nutritional status. Another study in 44% of people living with overweight or obesity found 48% of the overall sample, including all categories, were identified at risk. So really with this tool, we couldn't get, there wasn't enough research out there in the overweight obese population to conclude anything about the tool. Last couple now, we have the Nutrition Risk Index, NRI. So we had a couple of studies using this tool. So in a validation study where 57% of the population were overweight or obese, the NRI showed 22.4% sensitivity and 92.1% specificity compared with CT. Another study used NRI as the reference, kind of a switch over here, identifying 54% at risk of malnutrition with the kind of mean BMI of 24.6. So again, considering all BMI categories. And then there was one monomethod study. Again, you can't gather too much from that in terms of making conclusions for these tools. So what we kind of concluded was NRI's validity is questioned because it includes serum albumin, which is an unreliable marker of malnutrition to some degree. However, low albumin was not strongly associated with overall NRI risk. So it could be a kind of potential or have potential usefulness in the overweight obese population. And finally, we had the PGSGA, or the patient-generated subjective global assessment. And we included this because it also has the first part of the assessment, which is the short form, which is often used for screening. So with this tool, we found that one study where 54.4% of the population included in the paper were overweight or obese, the PGSGA identified more at risk than, say, hand grip strength, so a physical kind of functional marker. Another study where all the participants were overweight or obese, using CT measures versus PGSGA, found 64% at risk, and then a final study where 63% of the population were overweight or obese, reported 29% malnourished. So what do we take from these studies? Again, I know I'm only sort of providing you a very brief snapshot of these studies. I do include the link to the overall review and the end slide, so you can look more at this if you'd like. But the PGSGA, so the short form, is completed by patients and screens weight change, symptoms, and dietary intake. So this is the more subjective component of the tool. PGSGA is often used as a reference standard for validating other nutrition screening tools against, inclusive of subjective nutrition symptoms, so the short form version. And this could lead to detecting risk in overweight obese populations where objective measures may underestimate malnutrition in this specific population. Weight loss, reduced food intake, and symptom burden may therefore be key predictors of malnutrition, even when BMI is high. So it could be that the short form and those subjective measures could be a really useful thing to include as part of a risk screening in those who are overweight or obese. So I went through that quite quickly, and I know that was very text heavy. So as I said, I'm very happy to answer questions at the end, as much as I can. So now I'll just sort of take you through, so what does this mean? So as I said, when we went into doing this review, we understood that we weren't going to come out with a groundbreaking discovery. In fact, probably quite the opposite in some ways. But because no review that we had knowledge of had looked at this population and sort of combined the tools and combined the literature to look at, what studies had been done, we thought it was really essential to do this as a kind of first step or next step in the research. So our plan was always to kind of have this as a paper to talk about the next steps, and the kind of potential limitations and strengths of the different tools. So what are the implications then moving forward? So some of the key takeaway points that we found. So we found it really difficult to compare studies because they were very, very heterogeneous, but they also used different reference standards to compare to, which made it quite difficult. We had diagnostic accuracy studies using CT or NRI as the reference, and actually in one study they compared it, the CT was the reference and compared to NRI, and in another study it was vice versa. So this made it quite difficult because there was no sort of standard, reference method for this population. There was quite a lack of research specifically in people with cancer who also had overweight obesity, limiting the understanding. And as we found in a lot of the studies, they were sort of part of the entire population and didn't have a sub-analysis for them. So in some places could skew the results because of the range of the BMI kind of included altogether. Many tools do rely on BMI, which in this specific population may under-identify malnutrition in individuals with a higher body weight. So that's just something to sort of be aware of with tools that do use BMI as a key predictor in malnutrition. People with overweight or obesity may present with more advanced cancer in some cases, potentially. So this could be due to untreated malnutrition with lower referral to dietetic services, again, because they sort of seem well nourished. So this is maybe one of the reasons that they present with more advanced cancer in certain situations. Alternative or complementary approaches such as anthropometric and functional measures. So hand grip strength did come out quite a bit in the review, or maybe gait speed, and also tools with qualitative components may improve detection in this particular population. So they might sort of be additive to the objective components of tools to help understand malnutrition in the overweight obese population. And subjective measures alone, though, cannot confirm malnutrition diagnosis in the population. So although they can be used as sort of an additive, they can't, definitely diagnose or refer alone. And so some of the strengths and the limitations, well, yes, there were quite a few limitations. And again, we acknowledge this. So screening and assessment were actually used quite a lot in the research, in the literature, interchangeably. That made it quite difficult when we were doing our search because we had to unpick in some studies whether they were really referring to screening or were they using assessment but referring to screening, so especially sort of earlier studies. So that made it quite difficult. Distinguishment between overweight and obesity. So I said how a lot of the studies sort of grouped all BMI categories together, but actually overweight and obesity was grouped together, I think, in all of the studies. I don't think they were distinguished out in any of the studies. And actually they have different, sort of underlying pathologies, and when it comes to malnutrition screening, it would be beneficial to have these sort of separated out when looking at malnutrition screening tools. The definition of malnutrition varied across studies, which was interesting. So again, that sort of made it difficult because malnutrition, the definition was largely based on sort of all BMI categories again. So that was another sort of limitation of the studies that we looked at. Reference tools are often not validated for use in malnutrition risk screening in this specific population. So I guess raising awareness of this population and that, yes, indeed, they can still have malnutrition even though they are overweight. And a lot of participants from similar backgrounds, which made it sort of less diverse and less transferable across different backgrounds. So all kinds of sort of race, socioeconomic, etc. And then strength. So there were physical biomarkers that we found in studies. So although we didn't sort of specifically report on these, but it looked like when combined with screening tools, these can enhance malnutrition screening in this population. But we are very aware, again, I don't work clinically, so, I have all the clinicians sort of saying, yes, but time, and training, so we've got to also kind of balance what's feasible with what might be a potential for this population. And then finally, what are the kind of conclusions of the takeaway? So a uniform screening approach may not meet the needs of people with cancer and overweight obesity, and there's no clear consensus on a suitable tool. So again, we kind of went in knowing that this might be the case. But many existing screening tools fail to identify malnutrition risk in this population. And so from what we saw in the few studies that we did include, it seemed that there was a bit of a gap there. NRI showed potential, but evidence is limited to a single study, lack of validation studies, so it's really hard to kind of make a consensus on that, a firm conclusion. And combining subjective and objective measures and not relying on BMI may improve screening. So, for example, the PGSGA short form, components such as reduced food intake, unintentional weight loss, and appetite loss may be good indicators. So overall, evidence is sparse. No optimal tool can be recommended. However, these findings highlight limitations of current tools and provide direction for future research in clinical practice. And really, I think it starts that discussion or continues that discussion. Sorry, I know this discussion was already ongoing, but just kind of adds to that ongoing discussion around tools that could be used for this group of patients in this population. So those are the references I used in the study. If you'd like to kind of go, sorry, in the presentation, if you'd like to go through those in more detail. And there's just some of my publications as well around the topic, and some of them focus sort of specifically on the overweight obese population, but some more generally. And thank you. And I don't think I'm taking questions now. I think we're going to take questions at the end. So I will stop sharing and I will hand over to Tracy.
Great. Thank you so much, Shelly. I am going to try to screen share here. Thanks, everyone. So Shelly, thank you for that great setup. We were a great tag team to have to put this talk together. But so thank you everybody for joining us today. I'm going to try to get through giving you an example of what we're doing here clinically in practice at Sylvester for identifying malnutrition risk, and then give you one example in research of how we're trying to address this in the treatment period. So this is always a slide that I show frequently. If you've ever come to one of my talks, you've seen this slide before, but this is always my end goal. Like, how do we get to this place where all cancer survivors are given a prescription for both diet and exercise that's personalized? Today, I'm going to focus only on diet, but I always share that as my end goal. And across our lab, we have a number of trials that are intervening on lifestyle behaviors, but today I'm really going to focus on diagnosis and give you an example in the lymphoma trial that we're just now completing of what this kind of looks like. So during ambulatory care, and then give you a research example. So here at Sylvester, we have something called My Wellness Check. And My Wellness Check was really derived by Dr. Frank Pinedo. He really leads the Survivorship and Supportive Care Institute here. And how we do My Wellness Check is we have patient eligibility. Patients come in, and upon cancer diagnosis, at their second visit or later with any oncology provider, we are sending them several prompts. So this prompt comes through. It can be by text, by email. It also happens in the EHR. And they are given this e-health assessment via their patient portal. If they don't do it, we also try to collect it at the clinic. But part of this patient-reported outcomes and why this is relevant for this talk is we do things like anxiety, depression, fatigue, all these symptoms that Shelly kind of mentioned also that might be helpful, as well as nutrition needs. We also assess for practical needs such as financial or food security, rehabilitation needs, and quality of life. And then in real time, these are scoring in the EHR, and it's determined whether they need to have, if they don't have an alert that triggers, then we reassess them in the next 30 to 90 days, actually. If there is an alert, then we send them automatically a referral to either social work, nutrition, rehab medicine, or to the medical team, and then this is recorded in our EHR. And so the different measures that we use the PROMIS CATs for some of these patient-reported outcomes. We use psychological distress and cancer care delivery, and then we have value-based care. It's important for this for engagement, for technology optimization. How do you risk stratify? So when in a day where time and resources are limited, how do we know who has the highest level of needs in our cancer center, and who do we refer out when resources are limited? So malnutrition risk is common in ambulatory oncology, and we know that it may signal some broader clinical vulnerability. And patients with cancer, as no surprise probably to this group, often presents with unintentional weight loss, reduced appetite, inadequate nutrition intake, all of which can be contributed to poor tolerance of treatment and worse overall outcomes. And so we know this is important. So beyond nutrition consequences, malnutrition could also function as a broader marker of potentially clinical vulnerabilities. So in this study, we wanted to evaluate whether malnutrition risk was associated with worse patient-reported outcomes, increased emergency department use, and then increased hospitalization. And so we wanted to understand if this risk could be associated with these. So we examined specifically whether or not these relationship between malnutrition risk as measured by the Nutri-Score with symptom burden and quality of life, and then acute care utilization in this large, and Sylvester's a very diverse ecosystem and catchment area here, where 65% of our patients are Hispanic, identifies as being Hispanic. And so this was a really diverse population. And we also know, I should share this, that about 40% of our ambulatory patients complete the My Wellness Check assessment out of all the potential visits that could occur. About 40% of our patients are completing these assessments. And on a previous slide, I shared some publications that have already been published, broader context about My Wellness Check. But I wanted to dive in a little bit about the Nutri-Score. If you're not familiar with it, this is a There's two parts to the Nutri-Score. The first part is really focused on weight loss and appetite. You can see where you're getting different point categories. So have you lost weight involuntarily in the last 3 months? How much weight have you lost? And then have you been eating poorly in the last week? And then there's a part 2, which really takes into account cancer treatment and type. And as Shelly mentioned, there are limitations to all of these different ways that we assess, but we really felt like at the time that when we put this into play, we wanted to know who was at the greatest risk based on weight, appetite, and then the types of treatment they were receiving, to then send that automatic referral to nutrition support services to have follow-up. And for the Nutri-Score, when you add these two parts together, a score that's greater than or equal to 5 puts the patient at risk for malnutrition. So this is a retrospective cohort. We had 17,351 unique adult patients that were receiving ambulatory oncology care. This was collected between 2019 and 2024. And we assessed malnutrition risk using the Nutri-Score, which is this, again, like I mentioned, a validated tool. It incorporates all these different nutritional vulnerabilities. And then we examined the associations with both patient-reported outcomes, healthcare utilization, and these, as I mentioned previously, these were captured using PROMIS measures for anxiety, depression, pain, fatigue, and physical function. And then we utilized the FACT-G to collect overall quality of life. And then for healthcare utilization, we really focused on time to first emergency room visit and then time to first hospitalization. And this is utilizing our EHR data. And then we used univariate multivariable approaches. We used Kaplan-Meier estimates and Cox proportional hazards. And then this really allowed us to evaluate whether malnutrition risk remained independently associated with our outcomes after accounting for all these different possible confounders. And so I would just please share that this is paper that's under review. So I'll just make that statement. Okay, so what do we find? So high malnutrition risk was associated with worse symptoms, poorer functioning and quality of life, and substantially higher acute care. And so most importantly, I think, is that 25% of our patients were actually classified as high risk for malnutrition with that Nutri-Score higher than 5. And then after covariate adjustment, high-risk patients had significantly worse patient-reported outcomes, including fatigue, pain. They had lower physical function and lower overall quality of life. And then when we look at malnutrition and emergency room visits, we can see this was strongly associated, such that those in the higher Nutri-Score group, so you can see I classified that as 5 or higher as the blue line, and then less than 5 is on the red. It was the red line there. And so you can really see there's a 49% higher hazard ratio of having an ER visit, and this was, pretty substantially meaningful here, and that these all helped. So we looked at it over, I don't have time today to show you all this, but we looked across a variety of different tumor types, treatment settings, demographic subgroups, and these findings consistently hold both for the emergency room as well as hospitalization. And so if you can see here with hospitalizations, those in the higher group had a 59% higher risk of having hospitalizations if they were in the higher group. And then these, again, we're consistent across all the different tumor types. And so in summary here, the Nutri-Score really identifies patients with this oncology screening that it can really help. So having these frequent assessments really demonstrated patients that were at elevated nutritional and clinical risk. And so if you routinely screen, this can trigger earlier supportive care interventions that may improve patient-centered outcomes, reduce avoidable acute care, and then hopefully advance more equitable settings. So now in my last 10 minutes, I'm going to try to quickly show you what we're doing in one of our research trials to look at this. And by way of background, this is in a lymphoma cancer group. And so we know that non-Hodgkin's lymphoma is a little more common than Hodgkin's lymphoma, but there's between the two of them, about 90,000 cases every year. And the use of lymphoma modalities really either individually or in combination can lead to significant physiological and psychosocial symptoms and side effects. And when I first got to Miami, one of the attending physicians for the lymphoma group came up to me and said, fatigue is such a problem for my patients. Could we work together on something? And that's really where this study was born out of. And so in other cancers, I knew that lifestyle factors like diet and exercise had been shown to really mediate these symptoms, including fatigue, and improve overall quality of life. And so in this study, what we're looking at trying to, fatigue was really the most common side effect that's reported. 43% of patients have it with lymphoma, and it's more likely to be reported during treatment, actually. And then in Hodgkin's lymphoma, up to 37% of patients have pretty significant fatigue, and it lasts even up to 5 years and longer post-treatment. And we know that these patients who have higher levels of fatigue are more likely to less likely to be working, they're more likely to experience financial problems and have increased healthcare utilizations. And I should have had a better transition there, but with the Nutri-Score trial, the study that we did first that I presented, one of the patient populations that was at the highest risk for having a high Nutri-Score was actually our lymphoma patients. And so we've really felt like there's a need for intervention that reduced fatigue in patients with lymphoma. And so the Mediterranean diet pattern, as probably many of you are familiar with, we felt like this could be a good place to start. It's associated with a lower likelihood in breast cancer patients. Susie Zick has done some nice work here, looking at higher quality diets high in fiber, lower in total fat, high in fruits and vegetables, and omega-3 fatty acids and omega-6 fatty acids, very reminiscent of this Mediterranean diet pattern, can be associated with having lower levels of fatigue in women with breast cancer. And the mechanisms with action, just briefly, looking at these ideas of sickness behavior, that we have cancer treatment in itself is also causing these increases in inflammatory cytokines. This also acts on across the gut-brain microbiome, and that this is really the cause, and that the diet and the physical activity intervention here could help to reduce these inflammatory levels, improve the gut microbiota, and really help improve these levels of fatigue, and also try to help people stay on their treatment. So this is the study design. This was really a pilot trial of 120 patients. They came in, they were randomly assigned 2-to-1 before they started chemotherapy, and they were randomly assigned to either a Mediterranean diet and supervised home-based exercise or to this waitlist control. We assessed them in the middle, and then we did a post-intervention assessment as well. And so the lifestyle studies, they needed to be completing at least 6 cycles of R-CHOP, of BR or ABVD. So we took both Hodgkin's and non-Hodgkin's lymphoma patients because this was really a pilot trial trying to see, because there had not been much work done in the lymphoma space. So we wanted to know, would patients actually, try a lifestyle intervention during treatment? And so our specific aims were really focused on feasibility. 50% of eligible patients would enroll because we weren't sure, just starting chemotherapy in the lymphoma space. And then 70% of the intervention sessions would be attended. We wanted to look at retention and follow-up, and then satisfaction. Would they be happy with this? And then secondarily, we wanted to look at, do they complete their chemotherapy cycles on time? And then what happens with these patient-reported chemotoxicities, with a particular emphasis on fatigue. So where are we at now? So we have screened 271 patients. 56% of those patients were deemed eligible, and then about 120 of these were enrolled. So far and above, patients were interested and were enrolling on this trial. And so that's the good news, is that we hit that first mark of 50% feasibility. The number one reason those patients didn't enroll at 20%, roughly 21%, was feeling overwhelmed. So what do these patients look like? So baseline characteristics, about 40% are female. And as you can see, as I mentioned earlier, we have a very diverse patient population, and unsurprising, majority of these patients were non-Hodgkin's lymphoma patients and were receiving R-CHOP, which is the most common treatment for non-Hodgkin's lymphoma. And so what did our intervention look like? We really followed a very heavily prescribed Mediterranean diet with home-based exercise. I'm not going to spend a lot of time on the exercise, but just you can see what we did with the exercise goals. They did do strength training once a week with a trainer, and then once a week on their own. We provided them with a Fitbit so they could have they could track their steps, taught them how to use it. And then really focusing on the Mediterranean diet, we wanted to do 4 servings of vegetables per day, 2 of fruit, whole grains as the kind of the basis of that diet pattern. We were promoting legumes, which in Miami, beans and rice are a really common staple food. So actually getting those legumes serving per day was actually fairly easy. Nuts and seeds was a little more of a challenge, and then getting these 2 servings of fatty fish per week. I, for one, was hesitant here, thinking that I don't know that I could eat fatty fish during chemotherapy, but I'll show you here in a second that these patients actually did a pretty good job. And then limiting processed food, meats, added sugars, and alcohol intake. So what is our adherence been? This is a preliminary run because we're not quite done with the trial, but I wanted to show something. So about 79% of our patients are attending once a week nutrition sessions with a dietitian, and then 74% are attending the exercise sessions with the exercise trainer once a week. And then interestingly, I show the intervention arm in the orange line, and then the green line, I'm showing the control condition. We do see in terms of grams of protein per day, we are getting their protein intake up. I could not easily pull out the fish intake from the ASA 24, but eventually I will look at this. Nuts and seeds. They are eating more nuts and seeds, which is great as part of the Mediterranean diet. And you can see here their monounsaturated and polyunsaturated fats are definitely improving in terms of pre-post chemotherapy and above their control waitlist counterparts. Interestingly, when we look at depression and pain, we see early signals that they may be trending towards significant. They're not significant yet, but they are looking pretty good. So depression levels are actually coming down in our control condition, and then pain is actually being reported less frequently in the intervention. And then fatigue was significantly, it's still going up in the intervention arm, but definitely not as drastically as in the control condition. So I think this is important because it may not be that these lifestyle behaviors can completely mitigate these things, but it could be that they do in fact improve the rate at which, or the steepness of those curves in terms of the number of people who are experiencing these treatment-related side effects. And these side effects are what can really drive us to dose reduce, drive us to make changes in the chemotherapy, or not even show up to the chemotherapy sessions. So I think this holds a lot of promise. I don't think we're there quite yet, but it'll be interesting to see as we begin to look at these data as the trial wraps up. And of note too, I should have mentioned this earlier, we did do the PGSGA as our screening tool for this. And when patients came on trial, the average PGSGA score, if anybody knows that there's different levels, so 0 to 3 is at low risk for malnutrition, 4 to 8 is moderate, and then anything 8 or above is at higher risk. And most of these patients are coming in at about a 5 for their average score for the PGSGA. So definitely as they're coming into treatment, they are at risk for malnutrition. Okay, so in summary, I would say that these patients receiving treatment for lymphoma are definitely at elevated risk for these treatment-related side effects. There's been a significant lack of interventions that have really focused on lifestyle behaviors during lymphoma treatment. And then even during treatment, these patients are really motivated. They enroll. This has been the fastest accruing trial that I've ever had. And they are eager to participate in a diet and physical activity intervention. And as you can see by the race and ethnicity distribution, I had good representation of both males and females. And so that's important for us as we move on. So back to my first original slide, or what I hope for in the future. So I think we're really moving more from this nice to have to a must have. How do we get these lifestyle interventions integrated? And that assessing for malnutrition early and regularly is very important. And then if you're a provider, I think having time to talk about diet and refer to your dietitians are really, really important and key to helping our patients stay on track. I have lots of collaborators. I don't have time to thank them all, but I think it's pictures worth 1,000 words. This is my most amazing team ever, and I couldn't do any of this work without them. And I think I have done it, and I have left time, at least 10 minutes, for questions if anybody has them. So I'm going to stop sharing and end the slideshow for everybody and take us back to Shelly and Jordan and Emily.
Thank you so much, both of you. As a reminder, we are using the Q&A feature. If anybody wants to continue throwing questions into the chat, I'll be sure to collate them and read them aloud. But while we wait for people maybe to think of new questions and throw something in there, I'd love to get the conversation started. Again, thank you both for such great presentations. I think they complemented each other really well. Taking it back, Shelly, to your presentation, given the heterogeneity in study designs and the different reference standards that you discussed, what do you see as the most critical research priorities as we're trying to improve the evidence base for malnutrition screening and oncology, but particularly for people that have overweight or obesity?
Yeah, no, that's a good question, Emily. And Tracy, I think you're still sharing your screen, just in case you
hold
didn't
on,
know.
let me
So
stop.
if you want to, that's fine, but just so you know.
No, I don't want to. There we go.
Great. Yeah, very good question, Emily, and one that I will probably part answer. But to be honest, I think with, and with this Q&A, I know we only have 10 minutes, but and providing my email and after, I think it's worth having discussions about this because I don't have all the answers. As I said, I'm a researcher, I don't work clinically. But from what I understand from my collaborations on this project and wider and from the review, I don't think we're saying kind of replace existing screening tools at all. I think it's about sort of augmenting, what we already have, looking to see what tools or components of tools could be more sensitive to picking up malnutrition in this group. Maybe, where BMI doesn't play such a high factor in the overall score. And so Tracy talked about the PGSGA, and the scoring of that. So tools where BMI doesn't play such a high factor. But also I think, looking at sort of studies with validated reference methods, and looking more at those kind of studies as we really found those were lacking across the kind of tools and looking at validation studies going forward, or meaningful sort of reference standards that we can compare to, particularly for this population. So yeah, I think that's kind of the kind of key things. There's much more I could go on with, but I don't want to take up the whole time. So yeah.
Yeah, absolutely. And I think related to that, both of you really emphasize this need to move beyond these traditional weight-based approaches to malnutrition as we think about how we screen and develop, interventions to address it. If each of you could recommend like one or two key changes that clinicians or researchers should prioritize to improve this identification and management of malnutrition, what do you think that would be?
I'm gonna go
Do you want
first,
to go?
Shelly.
I don't
Yeah,
mind.
so I mean, I think it's all about, even if a tool is not perfect, screening regularly and routinely, I think is really important. And then having the resources or the programs to refer people to. One of the number one things that we hear from providers is that part of why they don't ask the question or screen is because they don't know where to send them or what to do if they
Mhm.
do identify this. And
Mhm.
so I think that's a critical piece. And then also, just again, looking for the trajectory and intervening early, because once you get on that slippery slope of malnutrition, it's really hard to get people back up versus identifying people at risk earlier. And as Shelley's mentioned, with other pieces that are important, body
Mhm.
composition and symptoms can really help.
Mhm. Yeah, no, I totally agree. And I think in that, screening early, but also, that kind of clinical judgment as well, I think is invaluable in terms of even if a tool's saying this, actually based on the symptoms or based on, what you see and what you feel, actually should they be sort of referred and then actually they're fine and, it doesn't go further. But I think, yeah, really picking that up early, but also maybe not just relying on sort of the outcome of the tool when it comes to this specific population of overweight obese and also using sort of clinical judgment, but as, body composition measures where feasible. And again, I know time is something that, is lacking for everybody, but whatever is feasible to do. So
Yeah, I guess moving then forward, what are there any practical steps that clinicians could take right now to move toward this more comprehensive multidimensional screening approach when they are in such busy clinical settings?
Mhm.
I mean, I think in the cancer space, something that I'm always thinking about is we routinely are doing body imaging for cancer care. And
Mhm.
if there is an opportunity to maybe look at body composition, right, as part of those routine screening tools, I think this is important because as Shelley's review so nicely demonstrated, you can't just look at someone and assume that they're fine and they're well
Mhm.
nourished.
Mhm.
Um, and so I think asking the question too, I think one of the things that we like about the Nutri-Score is that it gets away from BMI directly, but asks more about have you lost weight recently, which in the cancer space, in the acute setting, I think is important to be considering unintentional weight loss as an early sign that even if they look fine, they need to be watched and we need to at least be intervening early. And so I think I agree with everything that Shelley has found in her review. And and thinking about how do you take these things that are already routinely being collected and then asking specific questions like, have you recently lost weight and was it on purpose?
Mhm.
Yeah, I mean, I completely agree with you, Tracy. I think that that's exactly it. So it's, that intervening early, but also considering those more qualitative, subjective questions, which can be done, officially or unofficially. It can be during a sort of chat around
Yep.
asking some of those key questions, have you lost weight unintentionally? What's your appetite like? But incorporating, muscle mass, body composition elements where you can. And so, yeah, maybe also looking at sort of body composition approaches that are easier to do. Again, I don't work clinically, so I'm not fully aware, but, in some of our research, we're now using the ultrasound machine to look at body composition in different populations. So it could be that there are some sort of more feasible measures that could be utilized more quickly to do that. But yeah, I mean, otherwise, I completely agree. And I know, Tracy, you've got sort of a lot more experience in this area. So it's been fascinating to sort of hear your work that you've been doing, which very much does closely align to the review and the outcomes of that. So
Yeah, I think it is really nice to see the complementary nature of the work that you guys are each doing. Something, Tracy, that you mentioned is that you do work in a very diverse setting. It perhaps is not resource limited, but for those who are working in diverse or resource limited settings, what do you think might be the most feasible or high impact strategies that could be implemented now? So maybe they don't have access to regular scans or some of this more complex or expensive body composition data.
Yeah, I think asking, the key questions of have you recently lost weight? I think also do you have access to food is a key thing. Something
Mhm.
that we have learned here at Sylvester that I did not present on, but that we actually recently opened up a food pantry because we were finding that food security were on these health coaching calls with dietitian where just access to food was one of the major problems. And again, I think if you go just based on appearance alone, people wouldn't necessarily think to ask those questions. And so I think knowing also where you can send people for resources is important. So I think asking the question about, have you recently lost weight unintentionally? Do you have access to food? Do you need help accessing food? And then the other
Mhm.
key piece I think is, do you have, somebody there to help you? I mean, I think social support is another huge thing in the cancer treatment continuum. That's not always obvious thing to ask when you're thinking about malnutrition and you're thinking about how people are going to get through their care. And so a lot of times we're really linking up with social work early on. And I think part of the benefit of having a system where you're assessing for all the, even though only, again, 40% is not great, right? We're still missing 60% of our patients that we're asking these questions routinely, but it's still better than nothing. And I think it's at least getting them hopefully triaged quicker to where they
Mhm.
need to go. So I would say those are the key questions I would ask of patients, at least in the acute setting, right? I think when you get to the survivorship post-treatment setting, I think it can be a little different. But when you're facing a new diagnosis and you're really trying to help people get through their cancer treatment as best they can, I think those are the key things.
Yeah, those are great points. And I know we're about out of time, so I'll maybe leave it with you know, a couple more questions that have come in, and one is about the advent of and the more prominent use of GLP-1s, and wondering if this has impacted any of the work that you're doing or any of your ideas for where the field might be going in this space of overweight and obesity and cancer treatment and survivorship.
I think Shelly wants to go first.
Yeah, well, yeah, I mean, absolutely. So I guess next stage is, this again was sort of a very initial scope of what's there to then inform sort of next stages. So I actually have an activity with my class tomorrow that I'm teaching my first year undergraduates looking at GLP-1 and the kind of updated research around that. So, I don't have any sort of solid answers on that within our last sort of minute. But I think it's definitely something that will be considered going forward. I mean, Tracy, you can probably answer that more as somebody who sort of is in practice yourself.
So I would say we are seeing use of it routinely. In fact, even in settings where I did not think I would see it. I'm hearing about it. I'm not finding it in the medical record even. I'm hearing about it on the coaching calls with my interventionists, talking about patients taking this. I think it's so widespread now, asking the questions, are you microdosing or are you getting these from other places, is really important in the cancer space, because I think they're getting them, at least here in the United States, they're not just getting them from physicians. They're getting them from other places too. And so I think a lot more research is needed. I think they have high potential for maybe being helpful, but to Shelly's work that's been done in the body composition space, I don't think we fully understand what the interactions are going to be for cancer patients specifically between body composition, distribution, chemotherapy outcomes, and treatment outcomes. How are these going to interact together? I think there's so much work. The space is wide open. But most importantly, I would leave people with, you need to be asking the question and not relying on the medical record alone if you're doing research in cancer patient populations.
I think that's a great thought-provoking way to end today's webinar. I know we're right at time, so thank you both again for sharing your time, your expertise. It was really, really valuable and wonderful to hear you both speak today.
Thank you so much. Great job.
Yeah, thank you. Thanks,
Thank you so
everyone.
much,
Thanks for
guys.
having us.
Thank you. Have a good one.